So, congratulations everybody for staying the course and listening so attentively to everything. I've been asked really to present some work which I've done with the National Institution for Health and Care Excellence to kind of show that the lack of, if you like, take-up of these therapies, you're not alone. And I want to just take you through some of the experiences that we have gone through in order now for spinal cord stimulation at least to be commissioned. That means a service via the healthcare service. They recognise it as being value both clinically and cost effective to patients within our public healthcare system. So nice, and people always make the joke, it's saying it is anything but nice. But for spinal cord stimulation, it actually has been nice. It was created, this organisation, as the fourth hurdle after regulatory approval, and really to try and advise on, if you like, coverage of these therapies, whatever it might be, whether it be more typically cancer drugs, implantable cardiac defibrillators, but also spinal cord stimulators. And the idea was to reduce the variability and availability and improve quality of health and care in England and Wales, not Scotland. They have a different system. And they do this through a number of publications, which we'll come on to in a minute. But the point is that it is a rigorous process. And it uses the best available evidence and includes, importantly, the views of experts in the field, patients, patient representative groups, their carers, and of course, if it's a product, the industry. The topics for examination by NICE are referred by the Department of Health. And it is meant to be a completely independent and unbiased advisory committee. It's open and transparent consultation process. And it communicates its outputs through a number of publications. And the most august of those is the technology appraisal. And when they make a recommendation to the National Health Service that a treatment should be available because not only is it clinically effective, but it is also cost effective. That is meant to be a mandatory requirement of the payers of the healthcare concerned. So really they're saying that this treatment should be used. We're not going cap in hand to the funding agencies and saying, please could you help this patient whose case justifies it. This is more on the front foot, as we would say. Now, why is this process being done? It is obviously about the observation that healthcare expenditure continues to rise in every Western country, more so to your cousins in the south of you than everywhere else. And typically, European expenditure matches, probably similar to your expenditure of healthcare. And typically, they try to contain healthcare costs by trying to reduce demand. So, for example, in the UK, there's no direct-to-the-consumer advertising of healthcare drugs and what have you. It isn't allowed. I don't know what it is in Canada. Whereas, of course, if you go to the US, it's common that you will see drugs being advertised, if you like, in advertising hoardings. And the other way, of course, is to try and make sure that the healthcare profession does carry out clinical audit, and also that the use of your various approved drugs or devices is limited by particular formularies. And then, of course, you can affect the supply side by introducing profit restrictions or price volume agreements, for example, so that only restricted numbers of devices per year are funded. But we've now really moved to performance-based reimbursement. Does it do what it says on the bottle? So what? Does it make a difference to that disease management? And so when we talk about this extra hurdle, if you like, from regulatory approval through pricing and reimbursement and eventually formulary listing, and that's all known as a health technology assessment. And within NICE, we have referred, if you like, the topic. There's a lot of agreement about the scope, and the scoping of spinal cord stimulation was in the treatment of neuropathic pain and ischemic pain. And a university department independently was asked to draw up a systematic review, and industry were invited to put their submissions in. And then the evidence is reviewed by an expert body of volunteers. And often, I'm asked whether I want to volunteer, for example, to be on such a committee. And then that appraisal is made by that committee, in which, of course, there are health economists, but there is also input, as I said earlier, from healthcare professional groups, from patient groups, and other clinical experts. And we've talked about who the actors are. There are the providers, the assessors, and the appraisers. I don't know whether you've had this topic introduced, but this is the concept of how do we measure value in healthcare now. And obviously, if you have a treatment that prolongs life, there is great value to that, but also there is value to a treatment that improves health-related quality of life. Some might argue that the treatment of severe chronic pain might actually increase life, but mainly what we're trying to do is to improve health-related quality of life. If we put in an intervention, do we actually maintain that person or reduce their deterioration, if you like, in health-related quality of life over a period of time? And the difference between the normal trajectory in the dotted line and in the enhanced trajectory of their health in the hard line is the quality-adjusted life years gained. And one of the other sort of things is that if we, and the lovely thing about QALYs is that you can compare it to, say, the outcome of a liver transplant or a bone marrow transplant, or with a hip replacement. So you can use QALYs in all sorts of different diseases, and therefore help policymakers make decisions about the value, if you like, of each intervention. And one of the things you'll hear about is what we call the ICER, which is the Incremental Cost Effectiveness Ratio. And that's the difference between the costs incurred in acquiring this new technology minus the costs of current care over a particular time horizon, whether it be a year, 4 years, or a lifetime. And then you can add up the amount of QALYs that you achieve when you introduce the new technology versus the QALYs that you have achieved with your current care. And then that gives a simple sum, gives you an incremental cost of effectiveness ratio, or what is the additional cost per unit of healthcare gain. And that we can again compare from one disease to another. It also makes rather interesting decision making. And this is how we see how real politics, if you like, enters into healthcare decision making. We would all agree that if you introduced a new treatment and it improved your QALY difference but at a lower cost, any fool would say, let's fund that. That's a good treatment. The trouble is, there aren't many of them around. On the other hand, if something costs a lot more and actually the outcomes are worse, you wouldn't want to fund it. The truth is that there is a gradient, a line where your treatment might cost a bit more, but you're also getting an increased healthcare benefit. And the issue is, for our closed healthcare budgets, is what's that gradient? What's the state of our economy? What value do we as society put on a QALY for our fellow citizens? And it turns out that that might be between 20 and 30,000 pounds, 30 to 50,000 euros, 30 to 50,000 US dollars per quality. And we've done this with spinal cord stimulation in the management of what's known as the failed back surgery syndrome, but more properly should be known as chronic neuropathic back and leg pain. And it's just it uses existing data but structures it into a healthcare model that's been agreed by a number of experts informing the health economist. And you can have a decision tree that reflects 6-month responses to spinal cord stimulation. And you can add up the costs and the QALYs over, in this case, a 15-year time horizon. Chronic neuropathic back and leg pain is a long-term condition. You can find 6 health states in this model. You can have, and we heard 50% pain reduction is our responder rate. Some might say that that's a bit high, really, and that 30% pain reduction is more clinically meaningful. But we're stuck with this 50% improvement from baseline. And you can have that in 2 ways. You can have that plus a complication. You can have that without a complication. Similarly, you might have less than 50% pain relief with or without a complication. So that's 4 of our healthcare states. You can, despite spinal cord stimulation, end up with no pain relief. And there'll be a proportion who will. And you can die. And every 3 months, the model will allow patients to change in a varying degrees proportion based upon the literature and expert opinion between those 6 health states. Some might experience a complication, some might move from optimal to suboptimal, or even suboptimal to optimal pain relief. And some may switch to no pain relief and enter into a comprehensive medical management scheme, or even, if it's back surgery, even more back surgery. And some might die. And so you can create that model, and this is somebody's excitement to be able to look at how patients shift, and that can be informed on by the literature that we have. And so famously, one of Chris Kumar, an Order of Canada medalist, who died recently, and his famous study known as the PROCESS study, which I was privileged to be part of. We have data from another study involving back surgery as the comparator group. We know from our registries going on roughly how many patients per year will lose their pain relief. We know about the short-term SCS complications, which are quite high, and we know about the long-term complications. And then for the purposes of the model, it is assumed, although laughably, that complications in the reoperation group and in the medical group are assumed to be 0. And we know those figures, and so they can be plugged into that model I've described. And this is indeed the similar kind of methodology that NICE would have done. And we find that where spinal cord stimulation in this particular group of patients is compared to comprehensive medical management, that over that 15-year time horizon, the cost per quality is only £5,624. And if you use a reoperation comparator, it is £6,392, way below the £20,000 to £30,000, 40 to 60,000 Canadian dollars. So this is how NICE recommended to our public body that spinal cord stimulation is doesn't just work, but it's clinically effective, and it does it at an achievable cost. And furthermore, you can look at stressing that model with univariate and multivariate analysis, and we can see what are the important things that we need to try and achieve in order to achieve that. And so typically the one at the top is if patients, despite having spinal cord stimulation, don't come off some of the expensive drugs. And that can make it, push it towards being less cost effective. And so there are a number of this, from this tornado plot, of how we as clinicians look at our practices and try and improve it, and how the technology improves to have fewer complications. And one of the typical ones is this issue of rechargeability. Typically, many healthcare systems will only reimburse non-rechargeable devices. But actually that becomes cost inefficient because neuropathic back and leg pain and chronic pain is a lifelong condition. So as I've said, you can look at the cost of the things that affected the cost of adjunct pain therapy, the time before a replacement of the IPG, the cost of alternative therapy, if that were to increase, then the cost effectiveness. So in other words, more fancy spinal surgery or more expensive drugs will make spinal cord stimulation appear cheaper. And also we can try and reduce the amount of treatment failures at 3.24%. Every 4 years we go into the no pain relief by better technology. And that's how we publish the NICE technology. And as I say, this says that it's both clinically and cost effective for the NHS, and that all funding bodies should commission it appropriately. And in fact, it's mandatory. Sadly, because of a lack of cost effectiveness data and the wrong kind of comparator in some of the studies on ischemic pain for refractory angina and chronic critical limb ischemia, we were left to having that funded only as part of a research study. So there's no doubt that healthcare cost containment is a priority. Health technology appraisals informs reimbursement decision making. SCS is proven to be cost effective in neuropathic back and leg pain and complex regional pain syndrome. We need to optimize our practice and improve the technology. And we still need more trials to really grind this down, so there is no argument. Thanks very much.